come in today. We've got our meeting for our ER department, and the goal today is to avoid violent aggression in our emergency department. We have a goal of no physical or chemical restraints to use on our patients. We are the first contact when these people come into the ER, so we do not know what their background is, we do not know how they're going to act or what previous history is, so we don't know what we're up against. So we have to stay safe as well. Per Tischler 2013, we want to have a calm, inviting atmosphere with trained professionals on hand. The reason we need a calm environment and trained personnel is due to a 40% assault rate on the psychiatrists at their job. So that's the 1 in 5 psychiatrists that get physically assaulted by a patient. So that's significantly high, and nobody wants to be physically assaulted. Many are new to their jobs and need more experience, and they need to have the training and know what the warning signs are for the patients and how to care for the patients. So we want to have safe surroundings, and with what's coming in the door, we don't know what it is. We don't know if it's drug use or if these people are septic, if they're coming down on certain drugs, withdrawals, if they have some sort of head trauma. You know, we have to do some quick triage and figure out what is going on with these patients to help keep the situation safe and calm for everybody. So, of course, if you smell alcohol in a patient, you can pretty much determine that risk of violence is there. Per RUV in 2008, they say look for signs of agitation, guarding, combative posturing, threatening remarks, any type of irritability that things could just get out of hand very fast. So we need to learn how to see these signs and be able to react to them quicker and before anything escalates. We need to set our environment. We need to have a good number of staff. We need to avoid overcrowding in the waiting areas. We need to avoid small rooms, anything that would trigger anybody having anxiety or outbursts. Per Richmond in 2012, they say also to avoid loud noises, loud music, hot or cold temperatures, extreme colors on the walls. I mean, just anything like that would be detrimental to keeping a safe environment. So pretty much the homey, calm, colors would help. Limit projectile lamps. You don't want to have anything that could be thrown or that would end up hurting somebody. So probably lights in the ceiling would be best. So like I say, our goal is the patient safety and staff safety. We want to help the patient be in control of their own actions. So we need them to be a part of the care. Our body language is going to be the key to helping keep the patient calm. So they will respond to us. We need to be able to see what's coming. We need to be able to react in a calm manner. We need to be able to talk to them, reassure them, let them know that aggressive behavior is not going to be tolerated. And we need to have the staff around us as well trained, as well as security guards, and probably having plainclothes security around also, because sometimes if a patient sees a lot of officers in uniform, that could be scary for them also. So maybe a mix of both. Our goal being trained is to learn how to talk to these patients, collaborate relationships with these patients, and verbally de-escalate the situations. Per Bagian in 2010, the Joint Commission recommends assessing the areas of concerns and having layered levels of security. So just always watching. And per Antosamy in 2013, using a trust strategy. So gaining the trust of the patients is going to be key to working with them. So I believe we've got 4 weeks that we can work on this timeline of getting some training for our staff to know how to talk to these people, to de-escalate, and to make sure we have a nice, calm environment around. So let's plan on 1 month. We can meet together in 1 month after some training and reevaluate and have some feedback from all of our parties. So thank you very much for attending. Bye.